And the lecture is organized in the following way. First, we'll talk about what lung cancer actually is, and then about the epidemiology. So how common is lung cancer? Then we will look at the factors causing lung cancer, and then how do we diagnose this condition? How do we treat it? And then we'll also quickly look at the prognosis. Afterwards, at the end, like always, we will have one case where you're encouraged to participate. We will discuss a case, and then I'm looking forward to your participation. So, what is lung cancer? This is something we had spoken in the context of breast cancer already about. So, in the middle, you can see the normal cells, and they can undergo different physiologic or pathological processes. For example, a muscle cell, if you do sports, it can grow, then it's called hypertrophy, or it can go the other way if you don't do any sports, it's called atrophy. So this is something we usually observe, and this is in the context of physiological self-growth or self-metabolism. But there are also stages where, due to several factors, we have an abnormal reaction or development where we have first normal cells, which then are converted into metaplasia, and these cells are afterwards undergo several stages, and then we have dysplastic cells, and from these dysplastic cells we can have some cells which have sufficient amount of genetic mutations to turn into full-grown cancer. So this is a basic recap of what we had spoken previously, and the colleagues and the general preclinical subjects have spoken about it extensively. So a quick recap: so how does it look? How do we stage a tumor? How does the growth look? If you look at the membranes, we realize that there are different surfaces, different layers. And what's for us very important always to keep in mind is the basement membrane. So this is the second one here. It's important for us because as long as this membrane is intact, as long as no tumor has gone through it, then there is no possibility of the tumor spreading via lymphatic or blood vessels to other organs or other places in the body. And we also can see here that the tumors are graded depending on their size. So T1 is usually small, T2 is bigger, and so on and so forth. Additionally, we see how, in general, the metastatic spread can occur. We have these lymphatic vessels in which these cells can invade as soon as they have penetrated the basement membrane, and then they can go to other places. So then we have in the TNM staging, N0 means there are no tumor cells in the lymphatic nodes, and from N1 to 3, it tells us that there's an involvement and to which degree. What are causing, or what are the causes? How does the cancer cell look like? Which changes, abnormalities do we see? This is a quick overview which should just tell you that there are many processes going on within development of cancer, but also after cancer is present in regards to metastatic spread. So we have on the one hand metabolic changes, genetic changes, also changes that affect the immune system, and also on the one hand it reduces the capacity of the immune cells to destroy the cancer. On the other hand, it abuses immune cells by pretending that it's not harmful, and also encourages vessels to supply it with blood with fresh oxygen. This should also just show you the recent concepts or addition to what cancer actually is, because it's still not fully understood, and extensive research is being undertaken in this particular area of interest for us. And we can see that there are many interactions, because the cancer processes cannot be viewed in a local context, but we see there is, for example, also connection to the microbiome in our gut, but also to the age, for example, and in addition, what we have inherited from our parents. If you look at the cancers in general, at the incidence, meaning what is the most common cancer in the Western world, in general for both genders, we see that with 11.6% and 11.6% same for the breast, these two are the most common cancers. Obviously, breast cancer affects mainly women or only women. And in majority of cases, an absolute minority of cases, they are men, but this can be seen as only for women in this context. And then we see that number 3 is colorectal cancer. So we see these 3 are the most common ones, so they are present. And on the right side, if you look at the mortality, meaning which cancer is responsible for the most death, we see that lung is disproportionately represented here. Despite being only 8.6% of all cancers, it causes the death in 18.4% of all patients who die. So it means it's not only common, but it's also a very complicated, dangerous diagnosis. And here we can see, for example, for breast cancer, which is better treatable because of many different factors which you have spoken about previously, but we can see that the mortality is roughly half the size of the incidence. And if we look at cancer in regard to the gender, then we can see here, or to sex, we can see here that the prostate cancer is the most common one for men, while breast cancer is the most common one for women. And then the second place is already for both genders with 12 or 13% lung cancer. And if you look at death, that's more or less the same. So we see, despite being the second most common disease, lung cancer, it's in men and women the leading cause of death. Per year, we have, in this example, we can see that 36,000 women are affected and roughly 73,000 men. This just explains it again that prostate cancer is the most common one for men, and here we can see that lung cancer is the most common cause of death. So this should just explain to you or make sure that you understand, okay, it's not a rare disease, it's present, it's pretty common actually even, and it's not as easy to treat as, for example, breast cancer. So what are the causes for lung cancer specifically? This is a slide from a previous lecture where we have generally looked at more or less all possibilities that can lead to cancer of any type. So you see these red circles, they are focused on factors that are mainly causing lung cancer. And we see that smoking is very important because smoking is associated with the development of 80 to 90% of lung cancers. That's why stop smoking and all these preventive measures are extremely important in all places. And in addition, the second most common cause is radon. That's the second leading cause of lung cancer in uranium. So this is, for example, a gas. You can have interaction if you work in a construction sites or old buildings in a basement, for example. But majority of cases can be traced back to smoking. And here we see what kind of huge impact smoking has. Not only smoking, but also obesity. If we look at preventable causes of death, so how many people could have been prevented from death by cancer? If you look at the numbers per year, we see that smoking is leading it. It's more than 50,000 people who wouldn't have died if they didn't smoke, or at least had stopped smoking at a certain time point, and roughly 25,000 people if they did more exercise and lost weight. Lung cancer is classified in a relatively complex way. So for you, in order to make it as easy as possible, for me, it will be the most important point of the lecture today that you understand and remember that we have a classification for lung cancer. And the two most important ones are, which you need to remember, are non-small cell lung cancers, which make the majority of 85% of all lung cancers, and small cell lung cancers, making 15%. So as the name already indicates, it has something to do with the morphology and the histology if we look at it under the microscope. So it means these are small cells which are causing the lung cancer, and these are non-small cells, and they entail adenocarcinoma or squamous cell carcinoma or large cell lung cell carcinoma. But for you, the most important thing will be to remember there is non-small cell lung cancer, and there is small cell lung cancer. The majority is non-small cell lung cancer with 85%. And this is an overview. So within non-small cell lung cancer, which we have looked previously, so here, we have different groups. And the majority here is adenocarcinoma in 40% of cases, squamous cell carcinoma in roughly 30%, and then other types. And as we can see, small cell lung cancers make roughly 15%. The classification of these lung cancer types are complex. That's why we will focus on the basics today. So as already mentioned, we always make sure that we first understand whether it's small cell or non-small cell lung cancer. And for non-small cell lung cancer, the most frequent one is lung adenocarcinoma. The location is peripheral mainly, and there are here some characteristics. For example, they have often specific mutations on which we will focus later. And for example, in small cell lung cancer, they're more central. They have different characteristics. For example, small cell lung cancer produces hormones. So it means we have a cancer that produces hormones, and that itself can lead to clinical symptoms which might be difficult to understand. That's why it's important to remember that small cell lung cancer produces also hormones, and that needs to be kept in mind. And the location is mainly central. That's very important to remember. And here we have some specific information how to recognize them if we do histology in general. One special case, which I want to already mention at the beginning, is the so-called Pancoast tumor. So what does Pancoast tumor mean? It means that the tumor is at the apex of the lung. And in this area, so this is headwards, this is caudal, this is right, this is left. And here in the red circle, you can see that this is the tumor and this is the apex of the lung. So you can see healthy lung on this side, presumably healthy. And we see here's no tumor, and here we have a tumor. And here you can also see that we have specific nerves. So if the tumor compresses these nerves, we have, for example, the Horner syndrome. Because of these nerves that are affected, we have apoptosis, meiosis, and we have also red appearance of the skin on the affected side. And it's important to understand because sometimes patients might show up with this kind of symptoms, and it's important to remember if we have this trias of these three symptoms to always think also of the possibility of a Pancoast tumor, which is lung cancer that is at the apex of the lung. The clinical symptoms, what are they? So patients, it can be cough, it can be hemoptysis, it can be dyspnea, wheezing, chest pain. These are mainly symptoms associated with the respiratory system. And if you look at the extrapulmonary system, we can have weight loss. It's pretty common in more or less all kinds of cancers. We have fever, weakness in general. And as already explained, because of the anatomical location, we could have some compression of vessels, for example, superior vena cava syndrome, where you have the compression of superior vena cava, which impairs venous backflow to the right atrium, resulting in congestion in the head, neck, and upper extremities. The voice can also be affected. You need to keep in mind that there are a lot of nerves here, so it means it's not only the Horner syndrome that can be present, but also the voice can be affected. And in addition, what we have already mentioned, so dyspnea, if patients have difficulties breathing, and also very important if they have difficulties swallowing and eating. Recurrent respiratory infections, for example, pneumonia in the same region of the patients. And if the patient is below 40 years old, you should always be suspicious of lung cancer. If the patients come with the same symptoms, if they're quite young and maybe smoke, think always that it could be lung cancer. So these was the symptoms if the disease is more or less local. So if it's within the lung or within the thorax. So how can it be if the patient has already metastasis? So over half of the patients diagnosed with lung cancer have already metastatic disease at the time of the presentation. So 50% of the patients you will see in a clinic will already have metastasis, for example, as we can see in the brain, liver, adrenals, or bone. A mnemonic to remember is BLAB, BLAB, brain, liver, adrenals, bones. So there, the majority of the brain cell metastases go there. The lung cell cancer metastases go in majority of cases to the brain, liver, adrenals, or bones. And if we have brain metastasis, then patient can have headache, seizures, can focal motor deficits, or behavioral changes even, because if a certain region of the brain is affected, the character might change. And liver, in majority of cases, or in many cases, asymptomatic, but sometimes they can show also jaundice or ascites. And adrenal gland is typically asymptomatic. Bone metastasis can be very painful, and it's important, in addition to the first scan, X-ray or CT chest scan, to do also bone scan. This is a quick overview again of which places lung cancer metastases to. So we have the brain, the bone, the lung itself, of course, the liver, and the adrenals. How do we diagnose this condition? So if we are suspicious that that patient might have lung cancer, how do we detect it in a way that we are absolutely sure that this is a certain kind of lung cancer? The first and most important one is clinical observation. Always make sure to do the examination correctly, to make sure that you have checked everything, to include a blood analysis, to do in the first step a chest X-ray, and whenever necessary, if you see something on chest X-ray, you can expand the imaging by adding, for example, CT or PET-CT, and to finalize the diagnosis, we need a biopsy. This is an example of a case where we have a lung cancer patient with primary tumor here and one liver metastasis and two other lung metastases. In the PET-CT scan, you can not only see the morphological change, but also the metabolic change. So it means tumor cells here are quite metabolically active because they consume the glucose that we have given prior to the imaging. The first step in general is, as already mentioned, doing the screening. Screening can be done with X-ray or low-dose CT. And after the initial diagnostic steps, depending on the clinical presentations, it's important to confirm the diagnosis. And therefore, we need the histological biopsy to make sure what it is, because there you can, in the first step, say, okay, first, is it cancer, yes or no? And if yes, is it small cell lung cancer or non-small cell lung cancer? Molecular testing or additional imaging can be done in order to complete the staging. Staging means to understand how widespread the disease is, whether it's just in the lung or maybe already with metastatic lesions in a bone, a brain, or whatever. So this is a stepwise approach. Early diagnosis of lung cancer is challenging, as symptoms are usually mild or not even specific. So sometimes patients might go to the doctor and the doctor might think, okay, this is a cold, take some antibiotics, or you have some headache. So it means it's very challenging finding lung cancer in early stage in order to be able to cure it. This is one example. So a patient came to you with these symptoms I mentioned. You did first the X-ray, and then you saw here's something suspicious. And in order to confirm your first diagnosis, then you did a CT scan, and here you can see a lesion that's not regular. It has so-called spikes at the edges. And the next step would be to make sure that we get the biopsy to confirm our diagnosis. And in addition to that, do an additional scan of the whole body to see whether we have metastasis present. In this patient, for example, we have done also an MRI scan. And as you can see here, we see something that doesn't look healthy, right? It looks different than the rest of the brain. And additional MRI scans showed, for example, that this is the tumor. And because of the tumor growth, we have edema around it. It compresses healthy brain tissue, and the patient had strong headache and needed additional medication for that. So this was a patient with lung cancer who had already at first presentation brain metastasis present. This is also another case where we can see it. So it cannot, in the previous example, there were just a few brain metastases, but here we can see many in varying sizes. So it means they can be small, they can be large, they can be distributed in any place, and this patient has a lot of them. As already mentioned, so when we look at the patient and say this patient has lung cancer, then first step is to understand non-small cell or small cell. And if we have small cell, for example, then we can further subdivide them into limited or extensive. And in non-small cell cancer, we have stage 1, 2, 3, and 4. But in order to know which state it is, we also need to see how large the tumor is, whether lymph nodes are involved, and whether they are distant metastases. So it means we need a TNM system to know at which stage we are, because we need the stage to know which treatment we need, right? So these are two steps you always need to do in order to know, first of all, which state of disease it is, and then which treatment is the correct one for this case. TNM, quick reminder, T means tumor size. So depending on the tumor size you grade it, N means the involvement on lymphatic nodes, and M, whether there are metastases present. And in the case of lung cancer, as already mentioned, this is very complex. You don't have to remember this by heart. It's just to give you a first feeling how it works. So whenever we grade lung cancer, we first look at the size of the tumor, the primary tumor. And if it's smaller than 3 centimeters, then it's T1. If it's between 3 and 7 centimeters, it's T2. If it's larger than 7 centimeters, it's T3. And everything that invades mediastinal organs or bones around it, or if the tumor is on both sides of the lung, then it's T4. So this is the first step we grade. Okay, if it's, for example, 2 centimeters, then it's T1, and if it's 8 centimeters, then it's T3. The second step would be to find out whether lymph nodes are involved. If there are no lymph nodes, then it's N0, and here you can see these small black dots. N1 would be if the tumor is on the right side, and the lymph nodes are also on the right side. N2 would be the tumors on the right side, lymph nodes are also there, but we have a lymph node that's very central. If this one is affected, then it's N2, and N3 means lung cancer on the right side, and the metastases in the lymph nodes are on the left side, on the other side. So it means both sides of the lung are affected, then it's automatically N3. Metastasis, this is a bit easier. So we have no metastasis, then it's M0. We have metastasis, M1. So if we understand our TNM staging, as already mentioned, for example, T1 would be a patient with a tumor smaller than 3 centimeters, no lymph node involvement, no metastasis, then here's stage 1. This is early stage. This is description again, smaller than 3 centimeters, no lymph node, no metastasis. What is stage 1B? It means it's T2A, means the tumor is bigger than 3 centimeters but smaller than 4 centimeters, and no lymph nodes, no metastasis. It's also early stage. And then we go to stage 2. Stage 2 is, and you can see that that's why we always need a TNM. We always need to know, okay, where are we? How big is the tumor? What is necessary? And in order to understand at which stage we are. For small cell lung cancer, we just have 2 different classifications. And one we treat curative, where we try to heal the patient, and the second one where we try to reduce the symptoms and the quality of life. So if it's limited stage, we try to do intensive treatment, and this is the corresponding TNM stage. If it's T1 to 2 and 0 to 1, so it means we have no metastasis here. If there is no metastasis in small cell lung cancer, it's always limited stage. And as soon as we have metastasis there, then it's palliative and extensive stage. Here we can see how many patients with small cell lung cancer present with limited stage. Unfortunately, only 30% of patients who come to the clinic for whom you say you have small cell lung cancer have a limited stage. The absolute majority of 70% will have already at first presentation extensive disease. How do we treat it? I've taken this slide from a previous lecture because I want to make sure that you understand the concept that is for majority of cancers more or less the same. So this was for breast cancer, but we will see that this concept applies also even to lung cancer, because if we have a local disease, meaning a small lung cancer, then we can do surgery to remove it, or we can irradiate it, do radiation. And if it's systemic, it means if we have lymph nodes, if we have metastasis, then we have to do chemotherapy, targeted therapy. Hormone therapy is specifically for breast cancer, but this illustration or figure explains it in a nice way that if you remember this concept once, you can more or less apply it to all cancer diseases in general. If it's local, you try to remove everything. If it's systemic, you need to do something systemic, meaning chemotherapy or targeted therapy. The treatment of lung cancer, so the management is determined by the type of lung cancer, meaning small cell or non-small cell, and its stage. which stage is it? Is it stage 1A, B? Is it extensive? Or is it limited disease in small cell lung cancer? And if available, it's important to discuss this case with other departments in the multidisciplinary tumor board, where you have surgeons, oncologists, radiation oncologists, and anyone else who's necessary for their treatment, to make sure that we have the best treatment modalities chosen for the patient. Early implementation of palliative care improves quality of life. So what does it mean? We have a lot of patients who come to us and which we cannot cure. That's why it's very important in the very beginning to talk with them, to make sure that they talk to specialists who take care of pain or other side effects of this disease, or the systemic therapy or chemotherapy, to make sure that we not only prolong their survival, but also that the limited time they have, that they enjoy certain quality of life. And as already mentioned, the majority of patients you will encounter with lung cancer will be palliative, not curative. So now we'll go a little bit into the details. So how do we treat, for example, in this case, non-small cell lung cancer? What is important to us? And you can see these red circles. We have to know the cancer type, yes, tumor stage, and then we can find out which treatment approach we need, and whether the treatment approach is curative, which tries to heal the patient, or palliative, where we try to focus on quality of life and make sure that the patient doesn't suffer unnecessarily. So in non-small lung cancer, if we have stage 1 until 2A, and if there are no metastases, so it means it's a relatively small cancer, no spread, then the treatment is curative. We prefer doing surgical resection with or without chemotherapy, depending on several factors. But the most important information for you would be, okay, how do I find out what treatment does this person need? If we cannot do surgery and it's old patient with a small cancer, then we can do radiotherapy. Radiotherapy for early stages has same results as surgery. It means this is a treatment option for inoperable patients or patients who refuse surgery. And if for that same stage, if we look that the patient has metastasis, then we go here and we see that the treatment becomes palliative, because then we have automatically stage 4 because there are metastasis, and the tumor itself can be small. That doesn't matter then, because the presence of metastasis is the most important and limiting factor here. So if he has metastasis already, then what do we need? We need targeted therapy. Targeted therapy means if this patient has specific mutations, for example, of EGFR or ALK, then we can give certain medications that you could call them designer drugs. They go specifically to these pathways, signaling pathways of the tumor, and try to inhibit them, suppress them, and make sure that the tumor doesn't grow further or even shrinks. And if there is no mutation, then we do chemotherapy and or immunotherapy. So this is the general concept for non-small cell lung cancers. No metastasis, relative small, you can remove it, surgery or radiotherapy. We have metastasis, then we need some kind of systemic therapy. If the patient has some kind of specific mutations for which we have medications, then we can do this targeted therapy. And if he doesn't have these mutations, then we do classical chemotherapy and immunotherapy. Now for small cell lung cancer. So if we have limited stage, we try to treat it curatively, and here it's the same. We consider surgical resection, and all patients receive systemic therapy and radiotherapy. It's important also to keep in mind, because specifically small cell lung cancers, they spread fast, they're very aggressive, they make quickly metastases, and in many, many cases, these metastases go to the brain. So if and there might be this situation where they have already small cancer cells in the brain, what we can do, we irradiate prophylactically. It means before we even see that there is something in the brain, we irradiate the whole brain to make sure that either the brain metastases don't show up or come slower. And if it's extensive stage, it's palliative for small cell lung cancer. Here we do chemotherapy, as already mentioned, with or without immunotherapy. And here we can consider doing prophylactic cranial irradiation, depending on MRIs. Here we can also say, because it's extensive, the prognosis is very limited, maybe the patient will not benefit from additional treatment and the stress that's going along with it. Surgical Management, how does it look? So indications already mentioned. Early stage 1, stage 2 for both types of lung cancer. In which situations is it not recommended or it's not possible to do surgery? If we have N3 lymph node involvement or very large N2 involvement, if the patient is ill, if he has many cardiac risks, or if his lung is not working well, so it means critically limited pulmonary reserves because of smoking or whatever it was there in the previous history of the patient. Radiation, so radiation therapy can be done for limited stage small cell lung cancer, early stage or locally advanced non-small cell lung cancer. And the technique depends on the goal. So if we want to make sure that we have the best outcome, then we do radiotherapy and chemotherapy at the same time. In different scenarios, we can apply stereotactic radiotherapy. It means a very highly concentrated radiation therapy, but these are very technical terms. So in general, if you remember that for the radiation therapy, we can do it in early stage of small cell and non-small cell lung cancer. And now I think this is probably one of the most important slides here. How does the systemic treatment look? So we have a patient who needs now chemotherapy. Who needs that? So chemotherapy indication is, you can remember, for most lung cancer patients. And if you want to really make me happy, then you maybe remember one or two names of these chemotherapy agents. So cisplatin, and it's often combined, for example, with etoposide. And in another lecture, we will talk about the details of how these chemotherapies work, which side effects there are, what do they do, their mechanism, and etc. This time, we're just focusing in general that you have heard this term once. Targeted therapy, I mentioned it. So some patients, specifically with non-small cell lung cancers, have mutations for which the medical community has found specific medications. So for example, if we have an ALK mutation, then we can give alectinib, and it goes specifically to the tumor cells of this lung cancer and inhibits them because they have this mutation. And same principle goes also for BRAF or EGFR, for example. So we have there tyrosine kinase inhibitors. So they go specifically inhibit these pathways. In the next lecture, we'll talk a bit in detail about it. But if you remember that there is targeted therapy, but they work only in certain patients who have specific mutations, that's perfect for today. And the third big important systemic therapy is the immunotherapy. So the immunotherapy is recommended for locally advanced or metastatic non-small cell lung cancer and extensive stage small cell lung cancer. In general, the immunotherapy tries to help your own immune system to fight the cancer. So the cancer mimics and tries to reduce the activity of the immune system, and the immunotherapy stops that and helps your immune system to fight more efficiently the cancer and destroy it. How is the prognosis? So if you look at all lung cancer patients, and if we ask how many of them are alive 5 years after diagnosis, and unfortunately it's just approximately 20%. So after 5 years, regardless of which treatment we do through all stages, 80% of the patients will die. For small cell lung cancer, it's even worse. Even for the limited disease stage, only 16% of the patients will be alive after 5 years, and for extended disease, only 3%. And this is with the best treatment available in the Western world. Non-small cell lung cancer has better prognosis. It depends primarily, of course, on the extent of how large the tumor is, whether we have lymph node involvement, metastasis, and etc. But in general, if we have just a locally advanced or locally confined stage, so no lymph nodes, no metastasis, 60 to 70% of patients will be alive 5 years after diagnosis. So it's a huge difference if you look between 16 or 15 to 70%. That's why I mentioned it's the most important point to know at the first stage, is it non-small cell lung cancer or small cell lung cancer? Now we will come to a case. So I will read the case, and then we have questions, and then you will have time to raise your hand. Our moderator will make sure that you can talk, and then you give the answer. So in this case, we have a 50-year-old woman presents herself for preoperative testing before elective cholecystectomy. So it means she needed some kind of surgery, which had nothing to do with the lung, and the anesthesiology department wanted to make sure that her heart, her lung, everything works fine before doing the anesthesia. Her medical history is significant for biliary colic. She has a 40-pack-year smoking history. So it means for 40 years, she smoked one package of cigarette, meaning 20 cigarettes per day, and chronic bronchitis. It means that she had always some problems with her lung throughout all this time. She's afebrile with respiratory rate of 12 per minute. A chest examination is notable for diffuse wheezing, but no lymphadenopathy, clubbing, or breast lumps are appreciated on a physical examination. So on physical examination, it's not so suspicious, but on the X-ray of the chest, you can see a remarkable 3-centimeter non-calcified nodule, which has irregular margins on the right side and middle lobe of the lung. An X-ray taken 1 year previously does not show this. So there is something that's 3 centimeter large that developed within 12 months. And then the additional CT scan of the chest confirms this nodule, which enhances upon intravenous contrast and administration. So it means whenever you give an additional IV contrast, the contrast is enriched in this lesion, so you can see it more clearly. They did also an additionally tuberculosis test, which was negative. So what is the most likely diagnosis? You can raise your hands and answer the question. دکتر گل مهربانی سوال من کس جواب نمیتونه بده؟
استاد میتونه خمودس
خیلی تو بگوین مهربانی. آواز شما قطع شد. مهربانی هر کس جواب سوال میفهمه جوابشو بده. من یک نفر انتخاب میکنم والا. خب دکتر صاحب بشیر قیومی، مهربانی شما چی فکر میکنین؟
استاد ببخشید نمی سوال تا صحیح نگرفتیم.
امی سوال که من میال خواندم، یک خانم 50 ساله هستم، پیش از عملیات اینها را چک کردن، 40 سال هر روز 20 دانه سیگرت میکشید و در ایکس ریش یک 3 سانتی متر کلان لیژن معلوم شده و در سی تی اسکن هم معلوم میشه. 1 سال پیش که ایکس ریش گرفته بودن در اونجا شوشش نرمال معلوم میشد. به نظر شما چی هسته؟ کدام تکلیف هسته؟
استاد ما خود تاپک ما معلوم است که لنگ کانسر است و دومی که وقتی در اکسری ما میبینیم